Good morning. This is Barbara Wash from the Department of Medicaid Services. It is 9:58 and I'm still clearing the waiting room.
Hi, Aaron. Can you hear me? I've had a little more trouble this morning than usual, so I apologize. I don't know what is glitchy about all this.
I think it's in the air today, Dr.
Yeah,
Thornberry.
I'm telling you
Georgine
what,
was also having some issues. I think it's in the air.
it seems like the more important the meeting, the more trouble you're going to have. There must be some uh, corollary to Murphy's Law
Yeah.
about that. Remember we had that really, really important meeting one time we had this nationally guest and I could not get on. I don't know
Yeah.
what it was. It was terrible. It was somebody from the Commonwealth Fund. I don't know. It was terrible.
I was on a TAC one time in the middle at home in the middle of a tornado watch sirens going off. And so I'm like, let me take my laptop over here to my closet and keep running my meeting. So Dr. Thornberry, I wanted to take a moment and introduce you to Barbara Walsh. I think this is your all's first meeting since she's taken over. I have accepted a new position within Medicaid, and so I have handed all of the tax over to Barbara Walsh.
Hello,
Well,
everybody.
hi, Barbara. I knew that you had kind of transitioned there, and I'd heard about this.
Mhm.
We're going to miss you. We love having you.
Oh, why, thank you so much. I will be on. I'm still with Medicaid, same email address. So if you ever need me, you're always welcome to reach out.
Well, you're like our DMS mommy, you
Oh,
know.
well, I'm
We
still here, so I will help any way I can.
well, thank you, Aaron.
Of
We're
course.
going really going to miss you.
Thank you.
I think I'm here now. Can you hear me, Dr. Neal?
Hey, Dr. Neal.
I'm here too, this is Dr. Gupta.
Oh, hey,
Good
Ashmi.
morning. How are
How are
Oh,
you
y'all?
Ashima.
doing?
Hmm.
Okay, so this is Barbara um, Wash from the Department of Medicaid Services. It's 10:02 and the waiting room is clear.
Okie dokie. Do we have our quorum now? Let's see. We have myself and Dr. Neal and Ashima. Do we have our new colleagues joining us yet, or do we have our quorum?
Currently, you only have three,
Okay.
Aaron Leiden and Tuyen Tran. I don't
Uh-huh.
see those two. You're just missing two.
Good.
Do we want to wait to see? Because if everybody had a problem getting on.
Yeah, we'll give them a minute or two.
Okay.
What do we need? 4 of 5 or 4 of 6?
I think it's three of five. And
Well,
we
that's
have,
what I thought. So I
yep.
thought
So we
You
we
do.
have 3, so I thought we had a quorum.
Yep.
you do. Sorry, I was trying to find my mouse.
That's okay.
Dr. Evans is on, I believe. Kelly, are you on there? Here.
Yes.
Yeah, so with Kelly, I just don't see her on my screen. My screen I'm just having all kinds of. Let me expand this a little bit. Oh my God, we have tons of people. It'll be all fun today, won't it? So that's going to give us a quorum, but let's give it just a minute or two since we've had a little challenge or two this morning.
Okay.
We do have Dr. Stevens, and I'm expecting. Oh, he may be a little bit late, so maybe we just go ahead and get started if that's okay. Is that okay with you, Barbara?
Yes, that's fine with me.
Okay, well let's get this thing going here. Good morning, everyone. I'm Dr. William C. Thornberry. I'm the presiding officer here for the Physicians Technical Advisory Committee. Today is, don't tell me, October 17th, 2025. It's at 9:04 Central Time, 10:04 Eastern Time. We meet under the auspices of Title 19. We do have, let the record show that we do have our quorum. And I think the first one we want to do is approve the minutes of 16 May 2025. For those members that have had that, have you reviewed those, and are there any additions or deletions or corrections to that?
I didn't see any. I'll be glad to make the motion.
Okay,
Dr.
thank you,
Neal.
Dr. Neal.
And
Dr. Goop,
I'll
Gupta,
second.
thank you. Without objection, then those will be accepted and filed. Our first piece of work is some old business. I have us here. Let me pull this up on my schedule. This is 907 KAR 3005, our limitation on E&M services. We had worked on this last year. Cody, I see you on here. Would you mind setting that up for us so we can move into discussion?
Sure, yeah. So it's not a topic of conversation that should be unfamiliar to the TAC. This is regarding the DMS regulation that currently puts a limitation on evaluation and management services that are limited to one per physician, per recipient, per date of service. I believe at the May meeting, the TAC recommended to the MAC to recommend to DMS to remove the limitation from the regulation. And so I think you all just wanted to get an update on where that revision to the regulation currently stands.
Yeah, do we have anybody from the department that could speak to this on DMS?
Good morning, Dr. Thornberry. This is Jonathan Scott with DMS. Can you hear me?
Hey, Jonathan, I sure can. I'm going to mute here. I'm sorry, I got a jillion people on my screen here, so please just step right up, ma'am.
Sure, sure. We are in the process, hopefully, of hopefully there will be something very soon coming across, coming to a RegWatch email listserv close to you that will be addressing this, and hopefully a couple of other things that you'll find pretty friendly. But we are intending to remove that E&M limitation, and
Yeah.
just getting a few more things through our process and through our approvals process, but should be filed and ready to make it through the process. Hopefully in November, if not December.
We appreciate it, Jonathan.
Hey, good morning. Hi, Dr. Thornberry. This is Veronica Judy Cecil, Senior Deputy Commissioner for
Hey,
Medicaid.
Veronica. I didn't
Hello.
see you.
I don't usually get to attend these meetings. So
I know. This
it's
is nice
always,
to have
I
you
always
here.
have standing
What a pleasant
compliments.
surprise this is.
Yeah.
Yeah, what's going on?
Well, thank you, Jonathan, for providing that update. I do want to just note that there's some more intense scrutiny of our regulations that are happening by the legislature. So, as this gets filed and goes through the promulgation process, it really would be helpful for individuals who are very supportive of this effort and this change to make sure that they are communicating with legislators about the support for it. If there is when we go to the table before administrative regulation review, if there are folks who are willing to come talk and support it, just kind of putting that plug out there.
Well, Veronica, thank you for letting us understand that. This is with the as with everything, things change, and that we're going to be on pretty austere times here the next several years. I think that the intent behind this is, if I recall, the entire conversation was that in trying to help these providers do the work that they want to do. Sometimes the transportation is an issue. Sometimes we want them to handle actually a couple of three things in one appointment. And that's not altogether bad. I think in the long run, what we hope is that this will actually save money rather than being a line item of so much significant more expenditure. I'm hoping that in the long run, the things that we try to do here are about trying to save money in the long run, to be real instead of being penny wise and pound foolish. I think we are trying to look at the long view here. So, Cody, I think it'll be important for us to communicate to those people through KMA that were interested that they would need to make certain that if it's important to them, that they would want to use the resources available to them to speak to the members on that committee. I guess it's in front of uh, I guess what did you say, Veronica? Is it in front of the administrative committee right now? Is that where
Yeah,
it's?
well, no, not yet. It's not, it's going through the filing process. So
Ah,
it hasn't actually shown up
yeah.
for the Reg Watch and, on the table of ours yet. And it's the Administrative Regulation Review Subcommittee.
Yes.
We'll do I think, Jonathan, if we can, keep Cody and the TAC updated on when that does get filed and when it kind of becomes officially in the process. And I think the other thing, so definitely so first of all, let me say, I agree with everything you just said, Dr. Thornberry, about the purpose and the need, and that's why the department is moving forward with it. Um, uh, the other thing is, it's not just ours, but this has the potential to go through the Medicaid Oversight and Advisory Board if they want us to come talk about the regulation. And I'm only saying this because this has recently happened to us on other regulations. So just trying to prepare everybody for what might be facing us ahead. And then it could go to what are called the jurisdiction committees. So like this potentially could go before the Health Services Committee, the interim joint committee if it's with not in session, and then if in session, then the Senate and the House's version of that. So well, I just want to kind of note, like, we're happy to do this. We just kind of appreciate any support to get it through the process and into its final destination. And we'll do our best to communicate with you guys on where it is in the process.
Well, thank you, Veronica, and thank you to Jonathan. I think that entire process, I'd have to brush up on my Dante, but I think this whole process is like the seventh or eighth minor level of hell. I was down there Tuesday and it was a rough day. But I think, again, for those people that might be new members here, people that have not joined us before, part of the important work that we all do together, our MCO colleagues, the physicians, and DMS, are trying to solve these large problems. And again, what we're trying to avoid is certain carve outs for certain groups. We're trying to do very large things that are going to save us money in the very long run so that our Commonwealth can be sustainable. Uh, I think that we appreciate what you do. And again, Cody, now that you've made note of that, we can kind of get that to interested stakeholders. But if we can help you, Veronica, from the committee, we'll certainly try to have someone there if that's appropriate. We do see this as important for the work for the primary care workforce in particular. But we will do everything we can at this point. Thank you, Veronica.
Thank you.
Let's move us
Doc-
to this. Is that
Okay, Dr.
any other
Thornberry, could I make
discussion?
just a quick
Yes, Dr. Neal, I'm
question quick?
sorry.
Well, I just am concerned about how this may get presented and by who it gets presented, because I can tell you in the pediatric world, with the headwinds we're facing now with immunization, the other things, this has got to do with economic survival. And it's a really big thing because of well visits versus sick visits for pediatricians. So I just want to make that point, and I hope that some of us will be called upon to make that point. Thank you.
Veronica, if DMS or somebody from staff could kind of get to Cody and let us understand what the day that is. Maybe Dr. Neal, if you could represent us. For those that don't know, Dr. Neal's our emeritus chair, and there's no finer pediatrician in the Commonwealth than he. Dr. Neal, if it's possible, I would respect you as our member to help educate the committee and help them understand our concerns here. Would that be possible for you to maybe sneak into that committee meeting to support the DMS change?
Yes, as long as I get a heads up on when that might be happening, I'd be glad to do it.
Well,
just-
we'll get that. We get that. Those are publicly announced, obviously, and DMS will help us, and then Cody will see that as well. But we'll get that information to you, Dr. Neal. Okay.
Okay, that'd be great. Thank you.
Is there anybody that
Absolutely.
has anything else to contribute on this area?
Well, and just to level set, so it is a total like 9-month process. And Jonathan, keep me honest, probably we're talking 4 months or so before it gets on ours, probably on ours agenda, the reg review agenda.
Yes, it really all depends on whether we get comments or anything like that. It's a 75-day waiting period, comment period that opens up, and then it just depends on if we get comments, and then we can be deferred and delayed and everything from there.
Oh, I see.
But we will absolutely keep Dr. Neal advised of any, and Cody advised of any scheduling of the reg on an agenda. And so the MOAB, the Medicaid Oversight Advisory Board or Legislative Committee could potentially also just bring it up even before ours has an opportunity to hear it. So we'll keep you guys in the loop. And again, just appreciate any support as we navigate the process.
Thank you.
I see you now, Jonathan. So 9 months, huh? That I think I was wrong. I think it is the 9th level of Dante's Inferno that we're talking about.
I'm not sure that I can comment on that, but yeah.
Why don't you let me handle that one? I've not had a good week with that committee at all. Now that we have the new business out of the way, from the old business, I do want to just take a break and do a couple of things, some housekeeping. Number one, we want to thank Ashami Gupta. Dr. Gupta's been on our committee and has served on the MAC, and her term will end this December. We have Dr. Green, Kelly's with us today. But before I introduce her, Ashima, thank you very much for all of your leadership. Thank you for all the time away from your private practice that you've taken. And thank you for what you've done for the Commonwealth. I certainly want to acknowledge your work with that, okay?
Well, thank you very much, Dr. Thornberry. It's really been an honor, and I've learned so much in these last several years. So I really appreciate your support and being able to work with this committee and DMS.
Well, it has been a mutually shared pleasure. You're just a commensurate physician. We've greatly enjoyed having you as serve on this area. We had Dr. Lydon. I don't know if he's been able to join us today. He's our psychiatrist colleague. He'll be finishing up his work with the TAC, and I want to thank him for his service and all the meetings that he's attended. And literally, it seems like he's bailed us out with quorum a couple of times, but I am very much appreciative. I don't know if Aaron, if you saw him on here. I have so many people in front of me, I just did not see his name here.
My apologies. I was looking at an email. Who are we looking for?
It was Dr. Lydon. I didn't see him. If he's here, I wanted to acknowledge him, but I want to thank him publicly for all the work that he's done for us.
I do not see him, Dr. Thornberry.
Well, we have 2 new members coming in. We have what'll be our new OBGYN, Dr. Green, Kelly Green. Kelly, are you here somewhere? I saw you earlier. Felt like she was, maybe she had
See a
fallen
couple
off.
Kellys, but one only has a first name and one belongs to DMS. I do see a Kelly Evans.
Yeah, Kevin's it. Yeah, Kelly is. I'm sorry.
Evans.
I've got Kelly Green in my own hospital. I've got her on my mind. I've had a morning, but my morning started at 3:30 today. So this is like my 4th meeting. I'm sorry. Kelly, Dr. Evans is our OBGYN colleague. Kelly, could you tell us a little about yourself?
Internal medicine.
Oh, internal medicine? Oh, my heart be still. Yeah, that's my love. Well, tell us a little bit about yourself and your practice, please.
I'm a chief medical officer at Grace Health. We're a federally qualified health center with our main office in Corbin, but we have offices in 6 counties in southeastern Kentucky. Multi-specialty. We do have women's care, OBGYN, pediatrics, internal medicine, family practice, behavioral health, dental, and clinical pharmacy, as well as retail pharmacy. So we do try to help patients out. And for those that have transportation issues, we do struggle with that, trying to get patients seen for all their needs when they do come to the clinic. So.
Well, what an excellent repertoire of services that you're able to offer those people down in London, the London Corbin area. You say you're in 6 different counties, is that right?
Yes.
Well,
So,
well, thank you. And again, you're going to serve as our MAC representative for the committee. We appreciate that as well. Do we have Dr. Stevens on? Is Ish he was going to be a little bit late. Do you know, Cody, if he's made his way in here yet?
I didn't see him join. Let me double check. Yeah, I don't see him on.
No,
Yeah, Dr. Stevens, I think, is our immediate past chair of the Kentucky Medical Association. He was 1 or 2 terms behind the time that I had the opportunity to chair that work. Ish is an excellent mind. He's very well familiar with the workings of both the state and federal government, and so I think he will be a bright spot, and hopefully, like I said, he'll become one of our leaders as time moves forward in our committee. We welcome him. He practices pediatrics. Is he down there? Is it Ashland? Is that where he's at, Cody? It's that area.
Yeah, Ashland.
I thought it was Ashland, and if I'm not mistaken, again, I believe he's in a private practice. So that's always a real challenge. But I want to recognize those people. And again, we've already acknowledged to people that are not familiar with Dr. Neal. Dr. Neal's our emeritus chair, and there's just no finer pediatrician. Nor when it comes to this work, he knows where all the bodies is. I mean, he's been here from the very beginning, and I think on a regular basis he educates almost all of us about the history of this committee and the work that we're doing. That being said, I'm going to move us on to our work today. New business number 2, Cody, the DMS value-based program for this continuous glucose monitors and diabetes management. Do you want to set that up for us?
Sure. So at the last meeting, you all had Angie Parker and the Office of Quality and Population Health provided an overview of some of the value-based care initiatives that were taking place within DMS. Towards the end of that conversation, you all touched on CGMs and diabetes management efforts. And so I believe you had expressed at the last meeting that you'd like to have them back for some follow-up, more in-depth conversation around that topic. And so I saw Angie on, and I believe Ms. Harris from the Quality and Population Health branch will be on today to talk about this.
Hi, Angie. You were going to take the floor. Thank you for coming back.
Sure. We're glad to be here. Always happy to talk about some of the great work we're doing in the Division of Quality and Population Health. And as Cody mentioned, Letha Harris, and she will be presenting information regarding the CGM project that we've been working on for the past 1.5 years and give you some of the details on that. And so I will turn it over to Letha Harris. She is the Population Health Branch Manager within the Division of Quality and Population Health.
Yes, hello. Thank you for inviting us to come. I do have a short presentation to walk us through. So let me.
Letha, I stopped sharing.
Thank you. So we should be seeing that any moment, hopefully, if we did it right. All right. And you all left me. So can you all see the?
Yes, ma'am.
All right, great. Well, thank you. As she explained, for the past 2 years, we've been working on a project, and while it does address diabetes, it was specifically around accelerating the use of continuous glucose monitors in Medicaid. And it was actually a grant supported through the Center for Healthcare Strategies and funded by the Leona and Helmsley Charitable Trust. Project goals were to increase CGM access, which we know if that will help people manage their diabetes, which will lead to quality of life and lower health care costs and reduce disparities. There were 7 states in the project, and we were able to use up to $75,000 to help fund our efforts. And also through the project, we met monthly. We had a state convening cohort in Texas where we heard from leading physicians across the country in diabetes care. And we also worked on a lot of data, and because we wanted to know about our members. And through the course of the data, one of the first things that happened in the project was we worked with our healthcare policy team and the pharmacy team, and they actually changed the continuous glucose monitors policy. So in July of 2020, it was effective in June, but implemented in July of 2024. CGMs are now able to be accessed by members who are type 1 and type 2 diabetes, gestational diabetes, and then have the history of the problematic hypoglycemia as defined there on the screen. So prior to that, it was available for CGMs were available for type 1 and type 2, but the court had an insulin dependency requirement and some other things. And so now this is the new criteria. Now, this is for when members are accessing CGMs through the pharmacy benefit, which would be the majority of our Medicaid members. However, if they're fee for service, it should be going to the pharmacy. But if they may have a different payer as their first payer, they may go through what is now the Medicaid Supply Equipment and Appliance Policy. And the managed care organizations could also have CGMs access through that. And then there is a link on this slide, which will be shared with you all and posted on the TAC's website, that takes you to the Med Impact Supply and List criteria for CGMs. What we are going to be starting with the quality team, and that's who you heard from last time in Troy. They also, through the part of this project, with the disparities that are identified, which we'll talk about in a little bit more, they, reviewed, who should be accessing, what are the standards of care. So we've just kind of listed for them, CGMs across all of those that lead this, lead the efforts in helping CGMs. We really want to be one of the course options that are given for members to help them manage. So I won't read all those, but we know that there's a lot of benefits and a lot of information out there. So through that, they did look through and saw some disparities. As we mentioned, we know that our members with gestational diabetes did not have access, and they now do. And just for an example, in the first half of 2024, we had about 6 members access CGMs. And then after that policy change, we had 57, and then that has only continued to grow. And we are actually doing a study that we are going to see if that prevents them from going on and developing type 2 or having long-term health effects from those that did not have access and those that do. We also saw racial and ethnic disparities that we learned about. We do see a high prevalence of diagnosis amongst people of color, but we see a very low utilization of CGMs compared to non-Hispanic whites. And then what we also hope that we will see in our long-term studies, that those that now are accessing CGMs, we see lower cost of cares because not having to go to emergency rooms or having more acute problems because we're not managing their diabetes as they could with the CGM. So the focus study is going to be in partner with our managed care organizations and our quality team. And there are 3 objectives. We're going to look at evaluating disparities in the outcomes of CGMs access and the risk factors of lack of CGMs, evaluating the disparities in the CGMs, and looking at those prior authorization approvals for those members who do not access it through the pharmacy benefits. And then we're going to review the reasons for denial so that we can maybe remove any barriers that policies or programs might be, that our members might be encountering. And I won't read all those, but there's some methodology, and the peer review organization that is also leading this focus study. And then the quality team would say, through the focus study, it could lead to program improvement plan or as I stated, other policy changes. One of the other things that we did in this project earlier this year, we did a provider survey. So we wanted to kind of get the landscape of our providers who are serving our members. And we did focus to not get a whole lot of data. So if you did not get the survey, it's not because you missed out. We did look at Eastern Kentucky and Jefferson County providers, because in our data, that is where the highest concentration of our members who have a diagnosis of diabetes. And so we saw that the providers, have a strong involvement in their diabetes education. You are the ones that are serving the members and speaking to them with the diagnosis, following up in their care, and help them see the path to referrals for diabetes educators. You might be a diabetes educator. But we did see, they did notice that there are some gaps in consistent use of tools. Members may not be as comfortable in using CGMs or participating in diabetes support management education services. CGM use and practice, less than half of the providers surveyed regularly prescribe a CGM. Many rely on a referral to an endocrinologist for that CGM, and some express uncertainty about coverage and eligibility. And so those are some things we took and we've looked on, and I'll talk about here in a minute. Also, we really wanted to get, how do providers feel about diabetes self-management and education support referrals? And, there's some challenges in not only getting the member involved, but, providers hopefully making that referral and putting that importance on that program. So most providers refer patients, but, often rely on internal familiar resources that they know. There are some common barriers, including, where they are or how to complete that referral process. Some are not aware of how to send patients or initiate a referral. And the providers, several said that there's a strong need for better referral tools, a streamlined process, and education on available resources. So because of the survey, we then also, we created, that went live this summer, 2 Medicaid member and provider resource web pages. So there's a specific web page that is designated to resources for members, and then a specific web page within the Medicaid site for providers. And we list different resources varying from, public health, American Diabetes Association, all types of nutrition, mental health, our the Med Impact supply list, and more. So this is something that, it's nothing that we've developed, but it's a one-stop shop that members or providers can come to and really just click on to access all the great available resources that are available for members with diabetes. It starts on the members page, diabetes now what, diabetes 101. There's a lot to go into when they receive that diagnosis, or they have a member in their home or care that received that diagnosis. And so when you do visit the pages the first time, you will then get a pop-up that asks you if you'd like to subscribe to our Gov Delivery channels. I don't know how many are familiar with our Gov Delivery channels, but our cabinet and many departments have different channels that you can subscribe to. For example, there's a Medicaid channel, but then within the Medicaid channel, you can sign up for diabetes. Or in public health, you can sign up for different channels. Department of Community-Based Services, you can sign up for channels that help. You might get alerts about the changes around the application or certification processes. And so when you visit those pages, you will get prompted the first time if you would like to sign up. If you do sign up, it will ask you if you are a member or a provider, because one of the other things that we did in the project was we created a campaign messaging. So for members who sign up in the Gov Delivery, they will then get a series of dedicated messaging around diabetes and CGMs and diabetes resources. And that will, there are ones that are for everybody, and then ones that are member specific and ones that are provider specific. So while the campaign started in June and went to several thousand people, as other people join the Gov Delivery, the messaging campaign will then be shared with those new members. And then, this is something that we can continue and or change as we try to share about managing diabetes, pre-diabetes, and the long-term effects of poor management or the benefits of great management. Now, a lot of the things that we've shared above, from the resource page to the messaging, really point to our sister agency in the Department of Public Health. They have great diabetes resources, from their diabetes prevention program listed in the first box to the healthy living with diabetes in the second, and then diabetes 101. Now, these may not be available specifically in your local health department, but they are virtual options. So they are available statewide, while they have in-person and virtual options. And you can scan a code to learn more. You can also, their email is there if you would like to learn more, but they are great partners. Now, we know that they, cannot do it all, and are not the only one. Some of you, again, may have your own diabetes support programs, whether you're in a hospital or you're a provider office, or you might have access to regional ones, but these are the ones offered through the Department of Public Health, and do track outcomes. So and do track information. So I keep saying, one of the other things, there were lots of things we did over the 2 years. We really wanted to, when we partnered with our public health, which we could not have done any of this project without them, we wanted to look at the diabetes self-management education support utilization, because we want to chart, okay, this is what it was now, and all of our efforts, did we move the needle? So the things we looked at were DSMES participants in the type of diabetes. Type 2, it was the highest of those that participate in DSMES, but those that participate do lower their A1C. And so there are benefits to participating in these programs. And so this is data over a 2-year period. And so the average participant lowered their A1C by 0.7. I want to look at the average age, and you can see the average age is 55 years and above. And we think that's because also within our data, that's where we saw the larger people diagnosis, and that's type 2 diagnosis. But we did also, there's a lot that goes into diabetes. All of it's not only the diagnosis that our members are dealing with, but they may have special needs. So people who participate in DSMES, were visually impaired, they had low literacy, they had physically, disabled. So we have to think about those things when we're building and helping our members.
Siri, open Shazam.
They have very many barriers to care, from housing to utilities to food and transportation. And then we saw, we did look at gender, and high participants of female, but I will say when we looked at diagnosis, that's about 52, 53. It doesn't sway as much as it sways in those who are participating in DSMES. So we do see that males are not participating far near as many as females in DSMES services. So through that data, we also wanted to do some project expansions. So many of you might use Connect with your members or for yourself, and just went live at the end of September that diabetes is now a searchable subcategory. Before, you kind of had to figure your way around Connect to try to access diabetes resources. Now you're able, when you go to health and you look at management, diabetes is listed there for you to click on. And also through this, all the Connect partners work with all the health departments to list their diabetes programs in Connect. So you can see where your local programs are. You can also click and get a referral and information to make that connection for your member, or you can refer your patient to Connect to access resources. Also didn't want to, but there is a project report that some of these things I've just shared about, that the Center for Healthcare Strategies, who supported this project, has released a project activities that was released on 10/1. And so there's a link that you can click on when you receive this to read a full report about all of our state activities. I also just want to share, if you've not read, Kentucky every other year releases a Kentucky diabetes report, and that's from our public health partners, but has a lot of statewide and Medicaid data around diabetes. And it's very informative, and so I wanted to share that link. The last thing is, a lot of the projects that we did, we wanted to align when we saw this application. And Kentucky does have a statewide diabetes strategic plan over the next 4 years that started the last year, with 4 specific goals and objectives and strategies to achieve those, with the priority populations that I'll call out, which is why you know, as you can see on the strategic plan, it calls out people who live in Eastern Kentucky and rural areas, people of lower income, lower education, which, you know, align with what we saw in our data, and again, people of color and people of high risk in different communities. So, you know, this project aligns across not only Medicaid, but our cabinet, and I'm sure with you all. So I just appreciate you all allowing us to present about our project. Even though the project has officially ended, the work does not. So you'll probably be hearing more from us, and we look forward to hearing from you. And we have shared our specific branch email there. If you have any questions or want to hear any more specific or details or have ideas, please reach out.
Well, Letha, thank you very much. And Angie, thank you as well for this presentation. A couple of thoughts on this. You know, firstly, obviously our diabetics as a group spend more than anyone in the nation on healthcare. I noticed that we got at least a nice 10%, almost a full point of reduction, at least on the early data here. And I would, for those of people that don't work in this area, I'll tell you, when we do studies on diabetics, what the drug pharmaceutical industry always wants, they want somebody like an A1C of 12 or 13 or 14, because you do a study like that, you get a drop, and the drop is always more substantial the higher the A1C is. When you get closer to 7 or 6, the reduction is a lot more challenging. So to see almost a full point here from 7 to almost to just about 6, 7.7 to I guess 7 is a nice reduction. My hope is that, you know, with responsible technology, that over time the technology gets less expensive over time. But I can tell you in my private practice, I've seen much more dramatic results than this. Now, we are carefully selecting everyone. We don't, for our diabetics that are well controlled, we leave them on well controlled, the least expensive regimen that we can appropriately manage them with. But for our uncontrolled diabetics, we try to move them into this. And what I've seen almost without exception, maybe one or two exceptions of mine, entire time I've used this, is these diabetics do extraordinarily well. And I think it's a couple of reasons. One, when they begin to understand what they're doing or not doing that's causing their glucose to move up, they get almost immediate feedback. And those people that I think that take the time and effort to actually put this device on them do take the time to learn about it. And that's really a nice feedback loop for those people. I think secondly, there is a bit of a light bulb effect, seeing that, you know, now that they know that they're kind of watching themselves, they understand that we're watching them more closely. We always in our health system have a diabetic educator involved in this work. So it's been very successful for us. And that's why I was most interested to bring this back. Of all the things that I've done in the last several years, this type of work, this type of technology has been the most influential that I've seen in our diabetics. Dr. Evans, I'd really welcome your thoughts in your population as well. Are you all utilizing this? Do you see these kind of results?
We are using CGMs where they're covered. We don't look at one insurance versus another. So, you know, it's just when they're covered, we do use them a lot, and it does help the patients because they get to see immediately, you know, how certain foods affect their sugars, and it has been life-changing for some of them as far as helping to get them under better control. Some of the issues that I do have with them is some of my patients don't have smartphones, so they're using the transponder, but they're not savvy enough to help me out. So I'm not getting the results of what they're seeing the results, but I'm not seeing the results as far as trying to get them downloaded. We do have a couple of our pharmacists that are able to download some of that information when the patients bring it in. But it's also a little struggle if they are seeing a specialist and they are seeing us, only one of us can get that data. Yeah, they won't, the companies don't merge for the download for both of us. So that can be a little frustrating too. But it is, I do think that they are the best way to go when you can.
Dr. Neal, do you have any thoughts on this, sir?
You're muted, Dr. Neal.
There we go, sorry. Most of our severe diabetics, which are mostly teenagers, are referred to our endocrinology group, so I don't have any numbers for you.
Yeah. Well, I think the hope is that that before they get to Ashima, that before we have the small vessel disease, we can try to mitigate that early, particularly in our younger population. Those are the people that are obviously at more risk because they have more lead time before injury. But I've seen nothing but good things. And again, I would thank both Angie and Lethea for taking a few minutes out of your schedule to do this. Is there anybody else that has anything to comment on this topic
Dr.
before we move on?
Dr. Thornberry,
Yes.
actually, so just my anecdotal experience with my diabetic retinopathy patients. The ones that, I have had patients who I've been following for diabetic macular edema associated with diabetic retinopathy. And I have noticed just spontaneous resolution of the macular edema on some of my patients. I asked them, what have you done? They tell me they got this monitor and now they're so much more careful. They're able to bring their A1C down because of that. So, and then they avoid treatment, expensive, very expensive medical treatment.
Well, that's our hope. I think as these technologies begin to emerge, become more palatable for the patients, that hopefully we'll be able to access these to the people that will matter the most. Um, I wonder kind of what the prior authorization denial rate is for CGMs. That may be data that you all don't have. Letha, is that showing up on your radar yet?
So we have, I don't know if anybody from the pharmacist teams, but that is something we look at. Luckily our, having a single benefit manager, they do have which in my layman's term, kind of backdoor prior authorizations, so if they go to a pharmacy and they're putting a prescription in for CGM, the system checks for a diagnosis of diabetes and it should just fly through. So a lot of the prior authorization denials that they see are linked to maybe they didn't look far enough back into the record to find that at first, or it wasn't clearly, written in the record, and then they're easily to be prior auth. And then there are, a few other, but from what we understand, it's not as great. It's going to be more, we've got to look into that when they're not going through the pharmacy benefit. And that's where the focus study is really going to help us maybe pull out some more of those things. It's a lot easier when they're going through the pharmacy path, but not when they're going through the new medical supply equipment and appliances path. There's different doors they have to go through.
Yes, ma'am. Well, if again, is there anyone else that would like to chime in on here? Any of our MCO colleagues at all? Okay. Well, let's kind of move us along here. The next thing I have on my agenda is the overview of the social determinants of health surveys. Cody, would you set that up for us a little bit, please?
Sure. So some of the background on this, we've had a few physician practices, I think specifically peds practices, reach out, and some of them expressed a little bit of frustration over some of the differences in the SDOH survey formats across the MCOs. Differences in length, time it takes to fill out the surveys, complexity of the questions, those kinds of things. And so I think we just thought that it might be good just to get a general overview. If any of the MCOs want to speak to their survey, just kind of talk about some of the aspects of the survey, provider practice participation rate of the practices and filling out and completing those surveys and getting them turned back in. Also, maybe some better understanding about, to what extent is that data collected from the surveys being utilized by the MCOs or Medicaid to specifically improve those targeted areas for the enrollees. I think it'd be beneficial to hear from an MCO on any of those issues related to the surveys.
And Cody and Dr. Thornberry, before we move over to the MCOs, I just wanted to say, because when Cody had approached me about this, there is a member SDOH survey that members can, when they apply, at the end of the application, they can go through and do a survey and identify areas in which they are having challenges. This is data that we, within Medicaid, we collect and try to see where we can potentially address things. Rachel Rarick, who's in our research and analytics branch, does have a little presentation on what that looks like. If you want to see that, you may or may not want to, then that's fine. I know what the challenges are with the physician's office and doing these SDOH surveys. A lot of that, I'm not gonna say a lot of it. Part of that is we need to be addressing social determinants of health. And a lot of that can only be done in a physician's office, identifying those things and coding those things. I don't know how often that those types of questions are asked. And when you're seeing someone, you're having problems with transportation, housing problems, I think part of the SDOH aspect of these and these questions that are asked is getting a holistic view of the member or the patient that you're seeing. Because if they don't have housing or they don't have electricity, then they can't eat correctly, or there are those types of things that affect their overall health. So I can tell you that as far as one of the value-based purchasing program that we have with the MCOs, one of those measures is social determinants of health and being able to track that information so that we could potentially address any other concerns. The MCOs are also accredited in health equity. So part of that is probably contributes to some of what the providers are seeing, but I will shut up at the moment. See, number one, whether or not you want to see what the member survey looks like and what results we've had, and then turn it over to the MCOs to talk about some of what they're doing. But I'll leave that up to you.
Yes, ma'am. Well, I would very much welcome any thoughts from our MCO leaders that are here that could kind of give us their perspective on how they look at this. If y'all, I know we have Dr. Hoffman, Dr. Cantor, Dr. Flora that I saw on here. There might be more of our colleagues that I missed, but I would welcome any feedback that you all might offer.
Hi, good morning. It's Dr. Nicole Flora at Aetna.
Good morning.
I did want to just chime in. So we do look at these surveys regularly. We actually look at them at least quarterly. In addition to surveys we do on our own and the member survey that Angie referenced earlier. For us, it is challenging to address some of these things. But our biggest emphasis really is to identify, member needs. So we integrate this information into our care management platforms. So when we talk to members on the phone, we do try to overlay some of the social determinants of health information within their zip code or county area in order to make sure that we match them with potentially community services or services our care managers can provide. And then we also use them certainly around our population health program development and our value-added benefits development annually. If we see, we know transportation is an issue, it's a hard thing to solution. But all of these things we try to work into our strategy to meet the needs to get members to the care that they need. We would be very happy to hear from you all, though, certainly on, any individual solutions, any community partners that you're aware of that can assist these members. We can do so much, the state DMS can do so much, but the reality is, we really need to work with community partners as well. So between physicians and other organizations that you work with in your individual communities, we would love to hear more from you all on any of those good partners that you've identified that we could potentially enhance our relationships with as well.
Thank you, Dr. Flora. Uh, Dr. Hoffman, Dr. Cantor, do you all have a thought on this or anything to contribute?
Hi, this is Dr. Kelly. I hadn't yet
Oh, hi, Dr.
introduced
Kelly. I
myself.
didn't see you. I apologize.
Yeah, I was on mute, and when somebody mentioned my name, I couldn't get off mute, and we went on. But I'm if folks don't know, I'm the new CMO for Molina Passport, and I'm also a child, adolescent, and adult psychiatrist. So this is very near and dear to my heart. I'm new enough not to know everything that's going on in regard to social determinants of health within Molina and also within other opportunities in the state. But I had just started a committee meeting, one of 10,000, of course, to begin addressing social determinants of health within the plan and also within our vendors. So extraordinarily important to be able to work with the members for to solve their social determinant issues.
Any of our other physician colleagues have a thought on this or anything more to contribute? Well, one of the things that I thought Cody and I had spoken, as you can appreciate in meetings like this, we try to maximize the benefit of everyone here. So I have a meeting before this meeting that goes about an hour or two. But Cody and I had spoken before about the possibility of maybe this being an entree to maybe a pathway to increase the targeted messaging toward our beneficiaries. I kind of wonder if, with the technology that we have today, I want to use the simple rudimentary example of like a survey monkey. You know, I wonder if what benefit it is to have the MCOs collect the data from the people that they're actually taking care of. I mean, right now there's kind of like the physicians are coming. We're kind of between that data, and I think that there's a position for the medical community to try to engage patients with the care that they can in their community. I'm sure Dr. Evans can speak more eloquently to this than I, but I wonder if just getting the information directly to the MCOs, if that would help them in their work, as opposed to what we can do as physicians. I think we want to try to address every social determinant that we can influence, because that's one less problem and more likelihood that the patient can be compliance with their health care. And the needs of these chronic disease patients obviously are the great burden of the health system. It's what's at least 80% of the health cost of the dollar. So I don't know if that's a possibility. And again, I don't know whether tools. I would just mention. I hate to do this, but I want to just mention what's off the top of my head here. I hadn't thought this through, but in my private practice, I'm sure many of us are familiar with Chat GPT. About 1 billion people use it now. It's one of the many large language models that become available over the last 3 or 4 years. I built a free mini GPT for my own patients to answer kind of basic questions about diabetes, to help build them a diet plan, to recommend snacks and a grocery list. Um, I kind of wonder if that might be something that they could begin to offer. These things cost nothing now to the patient. Uh, there's, when my patients use, there's no benefit to me, but I've found that that's helped some of my patients do a little better with their diet. It helps answer some questions that sometimes may come up. A lot of these questions come up after the appointment. I might just suggest that might be an opportunity for, low cost or no cost information to the patient. It's very difficult to get a patient into a dietitian. I just found that this is, at least for my purposes, almost always, I'd say 90% of the time, this can solve the problem, as opposed to trying to get an appointment for, say, 2 months to a dietitian for an hour, and at the end of it, they just forget. And if they have a little app on their phone, or a mini GPT that they can ask a question to, or take a picture of and say, is this a good product for me? Do you have any other products that are like this? That might be just a consideration, an out of the box consideration.
Dr.
Does anybody?
Thornberry,
Yes.
I'm sorry, do you, your Chat GPT app
Yeah.
that you use,
Yeah.
that's something you developed, and how do you introduce that to your patients?
Well,
When they,
here's what I generally do. I'd say a year ago, 70–80% of the people had never heard of ChatGPT. Now I'd say it's less than 10%. Most of the people that I have. And so what I do is I literally show them my phone. I kind of pull it up on my phone. And the way I do it, Dr. Kelly, is I pull that little mini app up and then I'll demonstrate it in about 10 seconds if you'll just humor me. I don't ask me why I called it. I call it Medi Diet Helper. That's a terrible name probably. But I just pull it up on the app and I would do this. I would say, I'm a type 2 diabetic. I eat 2 meals a day and I like a lot of meat. I'd like to lose a little weight as well. My A1C is 8.3. Can you give me a 1 week meal plan with some snacks and maybe a grocery list for my wife? And then I just hit enter. And then what it'll do is, you may not be able to see this, but what it will do is, if you guys can, this is a terrible, this is terrible. But what it does, it'll make a little, it'll just give them a little diet. And then at the end of that, I go on a little bit more and I'll say, for Tuesday night at supper, can you give me 3 different recipes that might appeal to me? And it'll do that for me. And then the last thing I show them is at the bottom with these new GPTs, you can just take a little, you can hit this little plus button and it takes your camera, and I show them how they can take a picture of what's in the refrigerator, and that will make a recommendation for them and teach them how to cook it. And it costs no money to do. I mean, if you want to use mine, I don't get anything out of it. But I mean, or if you just, want to copy it, maybe some of the AI people from your side could just say, I'll just copy this or make it better and put your logo on it. The thing of it is, it answers questions, and it answers and these types of things are what large language models can do well, because there's a lot of recipes out there. You're not going to probably get a lot of confabulation, or what they would call hallucinations, bad data. Is very, 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 very unlikely. So I think it's good information. I'm not found our patients tend to like it. It costs them nothing, and to me, for a diabetic, I know I'm in a small niche here, but it's a really good thing for a diabetic. You can always, I do it for people that have, say, ulcerative colitis or Crohn's, or the people that have gluten sensitivities. It's very, very good for that. I mean, I don't want to put my registered dietitians out of business, but it's really difficult to get in there. And so we use this, and it's worked very well for me. And maybe if you all can take that back to your technology people and say, well, could we do something like this? Could you copy this? You're welcome. Again, you're welcome to look at our app. It costs nothing to these people. It's a good, cheap way to try to lower our health burden in Kentucky.
What did you say the name was that you're using?
Oh yeah, it's called Medi, Medi Diet, Diet, and that's kind of one word. I call it Medi Diet Helper. And if you go to ChatGPT and look under the GPTs, you should see it. You can play with it and kind of see what you think. If you guys have some feedback, can make it better, let me know, and I'll just change the prompt on it and I'll try to improve it for you. And it's not, I don't think it's anything special. I put a little knowledge base in there from some of the major dietary organizations that would be for quality diet. And of course, it'll have its own knowledge base, but you can play around with it and see what you think. And that's how I do it. I just demonstrate it. And then what I do is, at the end of the demonstration, Dr. Kelly, there's a little forward button. I just forward the conversation we did, the demo. I send it to them on an app so they can look back and say, okay, this is how I do it. There was nothing to it. It takes about a minute. And sometimes it's the best minute of the appointment for these people.
Sounds really cutting edge.
Well, if you guys have any trouble, just send me a private note or send me a text message on my phone. I'd be happy to send it to you. Again, it's easy to use. Maybe you all can do it. Maybe you can just take that. I did this a couple of 3 years ago, but maybe you all can make it even better. That would be even better for our patients in Kentucky.
Yeah, no, I think I think it's a great tool.
Yeah.
And the reality is, the structure could be used for a lot of different things, right?
Oh, yes.
Yeah.
Well, we all started, Dr. Flora, when I had a lot of people that are very anxious. So I actually made my first GPT on how to give patient information, because they have a lot of questions. I said, how can I give it to them in a very non-threatening way? Because they get something on the internet, they start worrying about it. So I said, well, can you give this to them? If my calcium level is up, does that mean I'm going to die? So I built this app to kind of calm them down. And then I said, well, if I want to do that, let me just give them something that will really help. And I built this diabetic thing, and it's kind of gone pretty well. I'd be very interested to see if it helps you guys. I hope it does. For every patient that we save in Kentucky, it's saving us money. and it's another family that we have that can be contributing to the Commonwealth.
Yeah, I'd also, I love that idea though, too, though, on your lab results of helping relieve anxiety, because that is
Oh
a
yeah, yeah.
source of
Well,
conversation.
I had to say, you know, I do this in a non-threatening way. I had to give it an example, but it works pretty well because you get, I mean, you get everything. It's like, well, my total protein is up. Was this me? What does this mean? Is this the end of me? I would get these questions on a regular basis.
Oh, for sure.
And generally what it does, it calms them down, gives a very simple explanation. It moves them back into the health system. Says, these are, let's make some questions. Let's ask our doctor about these questions. That's really what you want to do. You want the definitive source to come from the health provider, but they don't lose their mind before they get there, you know?
As opposed to, it's always a brain tumor and you're always dying, right?
Yeah,
If you
that's
just
what they
Google
want to.
it.
They forget about all that stuff. I am hypercalcemia. I want to die now. I have cancer. That's what it is. That is
For
cancer.
sure.
And God love them, you know,
You're
it's
you're
a tough
sounding
time.
like you're in medical school right now.
Yeah. I had HIV, I think 3 times in medical school, and I had lupus, and then all the hepatitis, I had all those too. Yeah. I go, that's me. I go, that's me. Yeah. Well, for you guys that are not the doctors, it's that way for every single student. It is that way all the time. They've had all these bad illnesses.
Dr. Thornberry, I'm laughing because I checked my chart while I was pregnant and was convinced that I had diabetes
Yeah.
because the number was red. So I'm just sitting here giggling to myself,
Well, you're in
which
good
I
company.
didn't.
You're in
So,
good company. Let me just say, okay. Well, I certainly don't want to exhaust the subject. We have a couple more things we want to get into. Is there anything else or anybody want to contribute or have any ideas on some of the other things in this area before we move on?
Dr. Thornberry, Dr. Neal, I'll be as
Yes,
quick
sir.
as I can. Just a bit of reality. Our group uses ECW, and we have a very long survey, and the parents, of course, fill that out for all our well baby visits. And so as you start to review the chart, as you see the patient, there's quite a bit of information there. Of course, we see a high number, all of us, of Medicaid patients. And so nutrition is extremely important. And of course, in the development of the children, we're talking a lot about diet and nutrition and that sort of thing. And, you know, have been feeling so smug in that we're now transitioning from curing sickness to creating wellness. And we've been enjoying that lately because we were starting to talk more about wellness and that sort of thing. But this tsunami that has hit us this year with immunizations is just overwhelming us as far as the discussions that we're going to have with our patients. And I think that's going to delay us a bit in what we'd like to be talking about with the patients. I can't tell you how devastating this has been to pediatricians, and I'm afraid it's going to get worse before it gets better. So we're trying, you know, on the one side of the Maha or whatever we're talking about, without getting political, we would love to talk about nutrition and that sort of thing, but I think that's going to delay us, and I just wanted to point that out.
Well, Dr. Neal, it's a point well made, and I won't belabor it too much. I think Dr. Kelly, our child and adolescent psychiatrist, could chime in on this. But you know, when you have, I think I think one of the lessons that hopefully the world, or at least our country, will understand and learn from something like COVID is when we shut people down. I didn't know how long it would take. I knew that as social beings, it would take a matter of weeks. I thought it might 2, 3, 4, 5 weeks. There's only so long people can really be isolated before they get really serious cognitive consequences. And I think what you're seeing is just kind of I think we've had that. I think we've gone through this period of anxiety. I know we're seeing with the Board of Medicine, we saw a lot more difficulty with substance issues. And I think one of the things that the unforeseen consequences is kind of what we're getting now is now you have this distrust of the medical system, for example, just by example, say vaccines, and that becomes very difficult. Or, you know, if you begin to utilize tools like, say, the health system in a political way, one side or the other, you're not going to get what you want in the long run, because in the long run, it's going to affect everybody and their family. And in our Commonwealth, I know there's a lot of suspicion. I have to entertain these conversations on a pretty regular basis. And it's going to take a while to work through this. Again, I think that, you know, should something catastrophic like this ever happen again, I think it's something we'll have to consider as part, you know, it's one thing to weigh you can weigh one thing, but you have to weigh other things as well. I think that we have to kind of decide as a nation and as a Commonwealth how we're going to work with this in the future when we have these future problems. What might be the wisest solution moving forward? It's easy to look back on that and the hindsight's 2020 and say, well, I shoulda, coulda, woulda. But we're still going through this, Dr. Neal. It's really going to take a little more time. I do feel it's getting better though. That's just my anecdotal thought on it. Well, let's kind of transition that to our next topic. I have some changes in the MAC and tax. We now kind of have what do I call the MAC and the back. Uh, who is it? Do we have a DMS representative to kind of lead us in this discussion?
Hi, Dr. Thornberry, it's Veronica again.
Oh, hi, Veronica. Can you kind of give us the 411 on this?
Absolutely. Thank you for having this as an agenda item. We are very excited that we have a brand new Beneficiary Advisory Council that we now refer to as the BAC. So we have a MAC, a TAC, and a BAC. The Beneficiary Advisory Council is made up of members, so current and former Medicaid members, their families, caregivers, or guardians. And we have a 15-member BAC that was just appointed and held their first meeting on Monday. Excuse me. These meetings are private. They're closed as the federal rule and regulations allow. This is to give those beneficiaries the ability to have conversations, to have a really safe environment in order to have those conversations. So they remain closed unless the members vote unanimously to open them. So it could be that we have back meetings that will be open to the public, and we'll keep folks updated on that. The Medicaid Advisory Committee, the MAC, we've had for a long time. It's more formally known as the Advisory Council on Medicaid Medical Assistance. It's been in state statute and federal regulations for like 40, 50 years. But the new law changed, the federal rule changed and the requirements changed. And so we had to make some adjustments to what our current MAC was, including adding additional members as required by federal law, and some other kind of really important requirements. So we have reconstituted a brand new Medicaid Advisory Committee. Those members have been appointed. It's now 31 members. We have several ex officio non-voting representatives from some state agencies that we expanded to. And that we have a new website for the Medicaid Advisory Committee and the Beneficiary Advisory Council. You can Google, the best way to find those are to Google it. And the list of the new appointees are both the BAC and the MAC are on there. The first MAC meeting is going to be November 3rd. We just posted that, the date and time, and currently it is virtual. We've been trying to locate an in-person opportunity, but are having a lot of difficulty finding availability that's accessible, that is large enough for folks who might want to appear in person. So right now it is virtual. And we are going to start promoting that in our social media, and that information is on the MAC website. So we encourage everyone to attend. We did send something out to the TAC chairs to make them aware, I believe. And
Yes, you did.
thank you for that confirmation. And so definitely want it, and all the TAC members are certainly welcome to attend. There's no change in the TACs, the technical advisory committees. They are still in state statute. They will still continue to meet. I think the only kind of impact to the TACs might be when your recommendations will be brought to the MAC. When that meeting schedule gets set, which will happen at that November 3rd meeting. The November 3rd meeting is organizational. They'll elect a chair, a vice chair, and a secretary. They'll adopt bylaws, and then they'll set their meeting schedule for 2026. And when all that happens, we'll definitely send that information out to the TACs to make them aware of it. I'm happy to ask any questions you might have.
Any
I'm happy to
questions for
answer, not
Veronica?
ask.
Well, thank you, Veronica. We certainly want to thank Dr. Evans for serving on the MAC on our behalf. And again, I'll just briefly point out Dr. Gupta's strong work in that area. It is a very large committee, and it makes things very challenging. And actually, that makes leadership even more important so that the correct business gets handled correctly. I've always felt like the working end of the MAC actually for us has been our TAC. We very uncommonly send things forward. We maybe once or twice a year do that, but the things are usually vetted pretty well before we try to move those things up to respect the max limited bandwidth. Let's kind of take us to our last working item here. Oh, and I did get a note before I'll forget. I'm going to do it now before I forget. Somebody wanted me to show the thing. I don't know if you can see, but this is the best I can do. This was the name of that app. It was on ChatGPT, Medi Diet Helper. Again, it costs nothing. I get nothing for it. You can copy it. I'm sure if you just probably prompt it and ask it what the prompt is, it'll tell you what it is. And I would hope that you guys can make it even better than I made it for those people that can use it. Our last agenda item is the Rural Health Transformation Fund, physician workforce. Cody, could you, that's a very important issue. Could you set us up on that, please?
Sure. As you have likely heard, probably a lot about this in the last few months. The Rural Health Transformation Fund, established by H.R. 1, provides $50 billion over the next 5 years to strengthen rural healthcare. And to access these funds, each state must submit a RHTP, or a Rural Health Transformation Plan, by the end of this year. The plan must explain how the state will improve access to care, enhance health outcomes, use technology and data, build and retain the rural health workforce, and ensure the long-term financial stability of rural hospitals. And then, so Kentucky is obviously in the process of forming its plan. And I think a lot of what the guidelines that were put out by the federal government in terms of what they would like to see in the state's plans kind of align with a lot of the different topics that you all have discussed over the last several years in terms of improving rural access to primary care services, just improving rural access in general, improving physician workforce. We know we have a significant physician shortage in this state, and that's been a big topic of conversation for the TAC. And so I think there's just some curiosity if, and again, it may be too early given that the plan is still in progress by DMS and the cabinet in general, but didn't know if there was some capacity to which the cabinet or DMS might be able to speak about the extent to which workforce, and specifically the physician workforce, will be a focus in the plan.
Thank you for that, Cody. And just to put a fine point to it, the application is due November 5th. We were given about 6 weeks from the release of the notice of funding opportunity to pull together everything that CMS, the Centers for Medicare and Medicaid Services, wants to see in an application. So it's a tremendous amount of work going on right now. And there is an expectation for states to provide data and other information to justify the direction that the state's going to go in for use of these funds. I think the only other thing I want to mention about the process is that states have this one and only one opportunity to submit an application for the whole 5 years. So one application that we have to submit right now is going to put forth the plan for Kentucky for the next 5 years with no opportunity to reapply or to amend the application. So it's quite a daunting effort, but we are up to that challenge, and we appreciate all the work of various organizations and folks across the state who have done a lot of help in providing us information and ideas and recommendations. We have to date received over 50 different pieces of input from various organizations on what, Kentucky plan could look like. It is still, unfortunately, very much in development, so I don't have a lot of information I can share at this time about the details. I will say that workforce is certainly part of the consideration in the development of the plan and what the state could do, as well as some other key areas, chronic diseases, mental health, maternal health, are kind of sort of the key areas that we're looking at, but we are still very much formulating what that plan might look like. And I think that one of the difficulties is that this is about transformation and sustainability. So we can't use the funds to pay for anything currently. So if it's already a covered service, we could certainly work to expand access to it, but we can't use it to supplant current funds that pay for clinical care, for example. We've also been told that, it shouldn't be used just to supplant funds that may be reduced as part of other provisions within HR 1. So we really have to think about what can we do with this money that's one time. It's over 5 years, but it's just going to be one-time funding that can transform our system of care for rural health. So that's, where we're going right now. And we're hopefully be able to provide folks a little bit more information over the next couple weeks prior to the submission of the application. I know there's interest in trying to get some type of feedback to the extent possible prior to submission, but all that kind of is the devil in the details of being able to get that completed and submitted. We certainly can't miss that submission date. So that's obviously our priority.
Well, we have a lot on the line. First thing I would want to do is I would want to at least acknowledge Brett Guthrie as a leading force behind this effort. The chairman, if I'm not mistaken, about 75 or 80% of the economy runs through his committee, and healthcare is, which would be this legislation would be something directly that he would be involved with. So knowing Brett, if it has something to do with not just healthcare, but rural healthcare, his fingerprints are on this. So I would acknowledge that. The second thing I would say is just what comes to mind, Commissioner, is the work that we did in 2018, which was a landmark work with our telemedicine to move toward having Medicaid reimburse this on a kind of a equal basis with our in-office care. And the reason that would be important to me is because this not only supports rural engagement, but it also supports the primary care practices. And our hope, I know we've never really been able to get great data on this to this point. I'm hoping that will come the next year or so. But our intent on using telemedicine was actually to lower the chronic disease cost care curve, so that we didn't have people in the ER, we didn't have people getting sicker, over 2 or 3 or 4 or 5 days, and then going to a more higher complex, level of care or more substantial expenditure to try to engage them with healthcare providers sooner. It was, I don't know how much of it was, it drives the cost down for acute care, but the chronic disease care part was the real hope that we could engage that, considering the fact that they don't cover service, or this application shouldn't be about services that we already have. I kind of wonder if there's a little Venn diagram between what we spoke about earlier, the economy, the artificial intelligence economy is moving toward not just these mini GPTs, but also an agent-based economy. And I wonder if there might be a line or two or a paragraph we could put in there to say that we understand this, and to the fact that we understand this, that we're working to develop agent-based mini GPTs, agent-based artificial intelligence to engage our beneficiaries to improve their health, like this dietary app that we're working with the MCO with our MCO partners. This is just one example, and we could put this example as something that we're working with now. And we could use this Medi Diet Helper thing and say, well, we're already talking about it. We're moving toward this. We want the government to know that we see this as where the hockey puck is going, and we'll ferret this out. As this becomes more available, we have a better understanding, and that would at least let the government understand that we can see where this is going. Because I do think that just as an economy, we'll be moving toward an agent-based network of applications that, not just schedule your hair appointment, your dental appointment, and your car working, but it'll also work with your physicians. And we don't really know where this is going. It's very early, but that might be a consideration. I would open the floor up to anybody that has any thoughts on this or can give us any insight from their point of view that might help our application.
I will say, Dr. Thornberry, bringing up AI is certainly something of interest for Dr. Oz, who, as you know, leads, is the CMS administrator. So we are very much, I know that all states, because of his great interest in AI use, is, we are trying to look at ways to incorporate that into the plan.
Well, I don't know Mehmet. I mean, he's a celebrity as much as he is a physician, but I really don't know him personally. I knew some of the last couple of CMS administrators I actually did know. Um, but if I can help you guys, or if I work in this area, obviously in AI, that's artificial intelligence was kind of led my work from telemedicine led me into that. So if I can help the Commonwealth or help DMS in this, or if there's a meeting I can attend to try to put our best foot forward, I'd be very happy to do so. Whatever I can do to help, again, any of our MCO partners, any of any of the state agencies, we want to use these technologies to bring healthcare into these rural areas, and I think that's going to make things a lot better. I do again believe that what's shaping up now is a type of market or different groups of marketplaces, and they'll have not only, I think most people will have, not, it'll go from 10 to a few hundred agents that work with us. And what we see now is you'll actually have agents, we call those archangels, agents that are supervising agents. What you might see is you might see Dr. Thornberry might be in charge of, say, example, rural health in South Central Kentucky. You can see where you have less physicians, but those physicians are going to be responsible for more and more different groups of there'll be a group of physician assistants, nurse practitioners, artificial intelligence, home health that work under that umbrella. I can begin to see this is where we're going with rural health. I mean, other people may have seen this as well, but I think that we're driving the boat toward that direction. We're becoming more efficient, and we hope that that's going to end up being better healthcare for all of us. Dr. Evans, do you have any thoughts on this? That's kind of, that London Corbin area is a soft spot in my heart. Do you all work with AI at all in your practice yet? I work with our health system to develop AI initiatives.
We're using it a little bit more with our meetings and helping us with note taking and with like policies and procedures and things. We just invested in going with Epic for our EMR. And so the group that we're with through that's hosting it, Ocean, is, looking into incorporating AI to help us with our notes and things, but we're not there.
For those of us for those on the call that aren't familiar, the artificial intelligence kind of where we call them AI scribes, that would be kind of the state of the art now. I think that what we're getting into, what we've not seen yet in our field, which I think will help more than anything, is having the artificial intelligence be able to look back into the medical record. Whereas a clinician, you can actually have a conversation like we're having now. You can have the conversation with your AI, and it'll become less a tool and more of a teammate. What was Mr. Smith's colonoscopy? Can you tell me when was that and what did it show? Can you graph the last year of serum creatinines or A1Cs? And we know that this is coming, but it's not been available, at least at this level of the public. I've seen some very nice demonstration models, but I think that'll help us as well in Kentucky. But to this point, does anybody have any thoughts for the commissioner to help to make our application more robust? Again, the only thing I thought was the artificial intelligence and saying that maybe we're using these GPTs, we're having the conversation, we're entertaining them now. We are working, we have these committees like the PTAC that are already invested in working with the MCO colleagues and DMS to begin to investigate these. I think that's fair to say that we addressed it today and it's on our agenda. I don't think I'm overstating that. Maybe we're fluffing it a little bit, but I do think that we have the kernels of a good idea and we can move those forward. Don't you think, Cody? Cody, you think that's reasonable?
Yeah, I think that's reasonable.
I would just put a plug in for rural health clinics and FQHCs as far as being partners in that rural health transformation and in the trying to utilize the physician workforce. Certainly we do need help in attracting and keeping physicians.
Well, I think in all fairness, if it weren't for FQHCs and rural health clinics, that there would be no legitimate healthcare in some of the counties. That I'm confident in saying. I think what I would say is being on many of these workforce committees in the past, that there's no real secret to us what actually is the very best way to get clinicians, particularly physicians, back to the Commonwealth. You have to identify them from the communities when they're in high school and or college. From there, you have to support them going to college, and you have to bring them back like the AHEC programs. I was part of that initiative when that first all got going. That was about the time that I was in med school, and we helped develop those. Actually, I was in the Lake Cumberland area, which kept me down here and put me in Glasgow. And so I'm a living example of that. But we do know the model, that's the model that works. You're not going to really get people, not very many people actually come from the outside, particularly in primary care, uh, and stay. So the secret sauce is, can you develop your own from these small towns? Can you encourage them? Can you support them? Can you bring them back? That is the model that works and has been proven to work decade over decade. It's just not easy to accomplish that, but it's not a secret as how to do it.
Yeah, and I would just say, just from the KMA perspective and in the recommendations that we had submitted to the cabinet, specific focus on increasing the number of rural GME slots. We know that oftentimes where residents are trained, sometimes they have a higher rate of staying there. And so just wanted to put that plug in.
Well, the rule is 80% stay within 80 miles nationally. I don't know how that works in Kentucky. Part of the reason I came back, I gave up a faculty position in Boston at Harvard to come here to start a residency program in family medicine. We celebrated this year 25 years, which means I've had a chance in my career to influence about 100 young doctors in primary care. And I thought that was a better, for myself, as the kind of goals that I wanted for a lifetime goal. I thought it was a better goal than it was to be up there in Boston. They have wonderful doctors up there, and there's lots and lots of them. I thought we needed more here. I would like to see more of that opportunity. And this would dovetail into that, Cody, would to say, to have, again, it's not where you go to medical school. It really isn't. It's where you train in your residency that matters. And so to have more of the GME slots, that gives us more opportunity. Can anybody offer anything to this? I feel like that we're standing between you guys and lunch, and that's not a good place to be on a Friday. But I would open the floor up for this or any other discussion items that we've not, or we need to bring up next time. I would welcome anybody that might have a note there.
Hi, Dr. Thornberry. I was just going to agree with what you just said. I was on the pediatric residency committee at U of L for years and years.
I know that, Dr. Therio. I know that.
And yeah, residents usually stay where they train. And so that it's not necessarily the medical students or increasing those classes, but increasing our residency spots would be very, very helpful in all primary care residencies.
And for the new members of the Technical Advisory Committee, those that don't know Judy, she's been a thought leader for a long time in Kentucky and has devoted her career to public health and this type of public health. And so I would say, Judy, thank you for what you've done for us, for the Commonwealth. Thank you for investing in your life in this aspect. We've all gotten a lot of it. There's not a meeting that I go to, I swear that you're not there. That's the truth. I think you're taking roll.
Just making sure you're showing up. That's all.
Yeah, I feel like when I'm not, I'm going to get a letter. Well, we have our next meeting scheduled in 26. We'll get those ironed out toward the end of the year. And of course, we won't have Erin to help us out. We'll have a new mommy, and then she'll kind of massage us in there. But we try to have enough meetings I try to generally skip the meetings when they're in session because that's really kind of a moot point for us. We try to do our work kind of outside the legislature to try to support their work and to support the work of our MCO colleagues in the department. Thank everybody for coming today. Again, welcome to our new members. I want to thank in particular Dr. Hoffman, Dr. Flora, Dr. Kelly, Dr. Cantor for being here and making time. Commissioner, thank you for coming. I love seeing you. I never get to see you. I cannot believe you're here today.
So thoughtful. Thank you. Well, I've enjoyed being part of it. And I want to thank you all for your service. It's a voluntary committee and you all show up and we appreciate it.
You're very welcome. It's our pleasure. Ashima, thank you for your service and thank Dr. Lyden who couldn't be here. Okay. Enjoy your weekend, everybody.
Thank you.
This meeting is adjourned.
Thanks, everybody. Have a great weekend.